Welcome to the December Ultrasound Case of the Month. My name is Greg Zahn, and I'm an assistant professor of clinical emergency medicine, a member of the Emergency Medicine Ultrasound Division. If you're new to the series, these cases highlight ultrasound utilization to help take better care of patients. As a reminder for the residents and staff, please email me if you encounter an interesting case that should be highlighted for educational purposes. Thanks to Dr. Jansen and Dr. Ferry for forwarding this case on. They were working together when this patient arrived as a transfer from an outside hospital. The patient had been treated and stabilized, yet needed to be transferred given the lack of dialysis capabilities at the referring hospital. The patient had arrived at the outside hospital complaining of fever, chills, and chest pain. The patient did have an extensive past medical history, including end-stage renal disease requiring dialysis through a subclavian vas cath. He'd arrived febrile to the outside hospital and received aggressive and appropriate care for his suspected sepsis. Broad-spectrum antibiotics and eventually low-dose norepinephrine was started given soft blood pressures. The workup before the patient was transferred did not reveal a clear source of the patient's suspected septic shock. Upon arrival at the downtown campus, the patient was found to be in no distress. He was communicating and able to answer all questions. His initial vital signs displayed tachycardia, fever, and a low blood pressure. Physical exam exhibited a chronically ill patient, no acute distress. Exam was non-focal and similar to the outside hospital documentation. The patient's chest X-ray was reviewed and official radiology report documented cardiomegaly with small bilateral pleural effusions. An EKG upon arrival displayed sinus tachycardia with nonspecific ST wave abnormalities. After initial assessment, repeat vitals were concerning for a pressure of 79/42. He had already received 2.5 liters of crystalloid and norepinephrine was running. Given the vital sign change, the team decided to perform a bedside ultrasound to further assist in guiding resuscitation decisions. This is the first image obtained by the team. As always, don't hesitate to mute the audio or replay the video to fully give yourself a chance at interpretation. While image quality is not perfect, it represents what we often see at bedside when scanning critically ill patients. The first thing you might notice is the patient's tachycardia. Next, take notice of the hypoechoic areas anterior and posterior to the heart. To help with image interpretation for the novice user, I included this slide as a review of normal anatomy in a patient with more clear ultrasound windows in the parasternal long view. The image on the right is a still shot with relevant anatomy depicted. In this view, we see a great image of both the right and left ventricle. Take a moment to fully interpret what you are visualizing. There is a hypoechoic area surrounding the heart, characteristic of fluid. While fluid is abnormal, it is not necessarily concerning unless it is impacting the functionality of the heart. In this image, we can clearly see bowing of the right ventricular free wall. The bowing is abnormal and should immediately raise the concern for tamponade physiology. The two previous images were in a parasternal orientation. This is now in an apical 4 format. We can now see a comparison of the right and left ventricle with the interventricular free septum going down the center of the image. We can again see the hypoechoic fluid with impingement on the right ventricular free wall, similar to the previous image. I was initially hesitant to show this image because it displays a slightly advanced concept. However, we're here to learn, and a discussion of utilization of M-mode in the diagnosis of tamponade is prudent. M-mode is utilized because it can graph things that are sometimes hard to visualize in real time, especially when the patient is tachycardic. For people newer to ultrasound, M-mode graphs movement along a line. To help orient yourself, you can compare depth in the top picture to the tracing on the bottom picture. What this M-mode tracing shows is that we get right ventricular free wall collapse during diastole, represented by opening of the mitral valve. We can see the tracing of the right ventricular free wall at approximately 4 centimeters and the mitral valve at approximately 9 centimeters. The dip at 4 centimeters represents free wall collapse, and the elevation at 9 centimeters represents opening of the mitral valve. If you've never seen this before, it can be hard to grasp. Thus, I include this slide to help show what we are visualizing in the echo image as well as the M-mode tracing. Diastole is identified by opening of the mitral valve, and we can clearly see collapse of the right ventricular free wall during early to mid diastole. After the ultrasound was obtained, there was a clear concern for tamponade physiology. The picture on this slide might be a little misleading because luckily the patient's pressure improved with additional fluids and he didn't require emergent pericardiocentesis. The image is worth mentioning because it shows a parasternal approach to pericardiocentesis, which would allow visualization of the needle for complete dynamic ultrasound guidance, something quite difficult to perform in a subxiphoid approach. Interventional cardiology was consulted. They reviewed the images and ordered a stat formal echo, which by no surprise showed the exact same findings as the point of care study. Cardiology did not feel a big enough pocket was available to safely perform pericardiocentesis. Additionally, they did not feel that the pericardial effusion was the primary problem. Instead, they thought the patient was suffering from severe sepsis with low-pressure tamponade associated with this hypotension. They recommended treating his suspected infection, and they would follow along and consider intervention if something changed or progressed. The patient was subsequently admitted to the ICU with multiple consultants following along. He gradually improved in the ICU and was able to be weaned off pressors. Initial cultures grew VRE and coagulase-negative staph. The source of his bacterium was suspected to be his indwelling dialysis catheter, and it was subsequently changed out during his hospitalization. He was discharged at his baseline level of health to complete a 2-week course of antibiotics. While ultrasound did not result in a heroic life-saving pericardiocentesis, it did provide information which allowed better and more definitive management of an extremely complicated anuric end-stage renal patient who had already received large volume fluid resuscitation. Once the patient's preload-dependent condition was identified, the physicians were more confident in giving additional fluids. Additionally, the case gives the opportunity to quickly discuss two concepts that I feel are sometimes misunderstood as it relates to cardiac tamponade. The first is making sure we identify that fluid around the heart is pericardial, not pleural, because you can imagine that management would change. As most of you know, a large pleural fluid collection can give the appearance of a pericardial effusion if you're not aware of how to differentiate the two. The picture clearly displays the difference based upon location of where the effusions track. The video on the left shows a clear pericardial effusion with fluid present both anterior and posterior. The key differentiator is the location of fluid in relation to the descending thoracic aorta. Pericardial fluid will track anterior to the descending thoracic aorta, and pleural fluid will track posterior to the aorta. I provide a color-coded still image of the video to further assist in image interpretation. The second key concept is that fluid does not equal tamponade. As we have all been taught, it's not the amount of fluid, but how fast the fluid accumulates. As little as 50 to 100 cc's can result in tamponade physiology. We must look at the heart and see how the fluid is impacting its function. The very first thing we will see with early tamponade is impact of the fluid upon the right atria. The right atria is the lowest pressure system of the heart, and we look for it to collapse in systole when it should normally be filling. A more specific finding of tamponade is found when the right ventricle is impacted. Collapse of the right ventricle during diastole is what we are looking for. This can sometimes be difficult to determine, hence the reason for showing the M-mode concept to you earlier. Additionally, don't be afraid to freeze the image and go through frame by frame, especially if the patient is tachycardic. Finally, if you think through the physiology, you should easily understand why a plethoric, minimally collapsing IVC is found with tamponade. A collapsible IVC carries a high negative predictive value for tamponade, and other causes of hypotension should be investigated if this is seen. Ben Smith at University of Tennessee developed this excellent diagram to highlight findings of tamponade on bedside ultrasound for a case he reviewed on his website. If you want more ultrasound content, I highly recommend the site. In order to keep things simple, the key takeaway point for all this is that pericardial fluid and a plethoric IVC should necessitate farther investigation. As we mentioned earlier, the sensitivity of plethoric IVC and pericardial fluid is extremely high, although its specificity is likely in the 50s. If you don't have the skill or the comfort level to perform advanced echo techniques, consider obtaining a formal echo or consultation. A formal echo will analyze all that we discussed, including some things I chose not to cover given their complexity, which includes things like flow velocity variation across the valves. Thanks for your time and attention on this review of cardiac tamponade. Continue utilizing ultrasound to provide great care for your patients. As always, email me with any questions or concerns.